Welcome to our second and last video on diseases of the liver. Let's begin. Here are the topics we're going to discuss in this lecture. Let's start with Wilson disease. We'll review introduction, clinical presentation, diagnosis, and management of Wilson disease, also known as hepatolenticular degeneration. Wilson disease is an autosomal recessive disease in which there is a defective hepatocyte copper transporting ATPase. The particular gene affected by the mutations is called ATP7B and located on chromosome 13. This defect leads to decreased copper incorporation into apoceruloplasmin and excretion into bile, which eventually leads to decreased serum ceruloplasmin levels. Subsequently, copper accumulates and deposits in the liver, brain, cornea, and kidneys. Patients have a wide range of presentations, including but not limited to jaundice, hepatomegaly, asterixis, hepatitis, and/or cirrhosis. Neurologic dysfunction manifests with ataxia, tremor, choreiform movements, and rigidity. Psychiatric problems such as psychosis, anxiety, depression, or mania can be present. Some patients might develop Kaiser-Fleischer rings, which is deposited copper in Descemet membrane of cornea. Here's an image showing Kaiser-Fleischer ring. Please notice this brown ring developing from copper that deposits in Descemet membrane of the cornea. Elevated transaminases are typically seen in Wilson's. Diagnostic findings include low serum ceruloplasmin levels and elevated 24-hour urinary copper excretion. On slit lamp exam, Kaiser-Fleischer ring may be detected. Other tests that may be needed to further confirm the diagnosis are liver biopsy or genetic testing. Treatment strategies for Wilson disease include giving copper chelators that will increase urinary copper excretion, such as penicillamine or trientine. Patients should follow dietary restrictions, such as avoiding shellfish, chocolate, and nuts, which are rich in copper. Zinc is also beneficial to its effect on increasing fecal copper excretion. In settings of acute liver failure, emergency liver transplantation is indicated. A 25-year-old man comes to the physician due to severe depression. He has used sertraline, followed by venlafaxine, and minimal improvement for the past 2 years. Physical exam reveals resting tremor and cogwheel rigidity. Lab findings are significant for ALT of 300, AST of 280. What's the best initial test to diagnose this patient's underlying condition? This young man presents with treatment-resistant depression. Physical exam reveals resting tremor and cogwheel rigidity. The Parkinsonian signs suggestive of basal ganglia involvement. Additionally, he has signs of hepatitis with high ALT of 300 and AST of 280. Psychiatric diagnosis, Parkinsonian features, and hepatitis in a young patient raise suspicion for Wilson's disease. The best initial tests for Wilson's disease are measuring serum ceruloplasmin levels, 24-hour urinary copper excretion, and slit lamp exam, which typically shows Kaiser-Fleischer rings. Next, let's talk about hemochromatosis. We'll cover definition, etiology, clinical presentation, diagnosis, and management. Hemochromatosis is a condition of iron overload in which iron accumulates in several organs such as pancreas, liver, heart, and pituitary gland. The etiology of hemochromatosis can be genetic autosomal recessive mutations in HFE gene on chromosome 6, which leads to excessive absorption of dietary iron. This is known as primary hemochromatosis. Some patients who are receiving chronic transfusion therapy, such as thalassemia patients or having ineffective erythropoiesis, such as sickle cell disease patients, might develop secondary hemochromatosis. The classic triad of hemochromatosis is cirrhosis, diabetes mellitus, and skin pigmentation. It's important to know that hemochromatosis put patients at increased risk of developing hepatocellular carcinoma. Iron deposition in the pituitary gland leads to hypogonadism, impotence, and/or amenorrhea. Arthropathy, especially of metacarpophalangeal joints, may be seen due to calcium pyrophosphate deposition. Cardiomyopathy, either restrictive or dilated, can be found and subsequently leads to heart failure. It should be noted that hemochromatosis does not affect lungs, kidney, or eyes. The best initial tests for hemochromatosis are iron studies, which show increased serum iron, increased serum ferritin, and increased transferrin saturation. Genetic testing, which detect HFE gene mutation, is also indicated. MRI can be used to quantify the iron within the liver or heart. Lastly, liver biopsy is indicated if there is suspicion of fibrosis or cirrhosis. Let's look at this histologic image from a liver of a patient with hemochromatosis stained with Prussian blue. We can see the iron deposition here. The first-line treatment for patients with hemochromatosis is repeated phlebotomy. Iron chelating agents such as deferoxamine, deferiprone, or deferasirox may be used in some cases as well. A 45-year-old white man presents to the clinic with decreased libido, putting strain on his marriage for the past year. He complains of pain in his metacarpophalangeal joints. He was diagnosed with type 1 diabetes mellitus and diastolic heart failure last year. Physical exam reveals dark skin discoloration and right upper quadrant tenderness. What is the most likely diagnosis in this patient? This man presents with decreased libido for the past year that may indicate hypogonadism. He also complains of pain in his right metacarpophalangeal joints. He was diagnosed with type 1 diabetes mellitus and diastolic heart failure last year. Physical exam reveals dark skin discoloration and right upper quadrant tenderness. Hypogonadism, arthalgia, type 1 diabetes, diastolic heart failure, bronze skin discoloration, and hepatitis are signs of hemochromatosis. All these signs and symptoms are caused by iron deposition and dysfunction of respective organs. Let's talk about pyogenic liver abscess. We'll cover definition, etiology, clinical presentation, diagnosis, and management. Pyogenic liver abscess is a collection of pus within the liver. It's the most common type of visceral abscess, and the most common isolated pathogen is E. coli. There are many causes of pyogenic liver abscess. Most common are those related to biliary tract as a primary source. For example, cholelocholithiasis and cholangiocarcinoma that obstruct the biliary tract and predispose to inflammation and infection. The source of infection may be hepatic artery, like in the setting of sepsis and bacteremia. Other conditions that may lead to liver abscess are intra-abdominal infections such as peritonitis, as well as Crohn's disease. Lastly, the abscess can develop as a secondary bacterial infection to hydatid cyst or amoebic liver abscess. The classic triad of pyogenic liver abscess is right upper quadrant abdominal pain, fever, and malaise. Other observed non-specific symptoms are nausea, vomiting, and weight loss. On physical exam, we may see jaundice and tender hepatomegaly. The lab values that are typically detected in pyogenic liver abscess include increased serum transaminases and alkaline phosphatase. Also, inflammatory markers, ESR and CRP, are increased. Leukocytosis is usually shown on CBC. Abdominal imaging shows one or more space-occupying liver lesions, most commonly in the right lobe. Blood cultures are essential as well. Aspiration, gram stain, and culture of the abscess material should be performed, and the aspirate typically looks purulent. Here is a CT image showing multiple liver abscesses, as indicated by the red arrow. Management of pyogenic liver abscess depends on drainage and antibiotic therapy. The abscess drainage can be percutaneous or surgical, based on number and size of lesions. Empiric broad-spectrum antibiotic therapy should be initiated, followed by tailoring the regimen when results of staining and cultures are out. Let's conclude our lecture with amoebic liver abscess. Amoebic liver abscess is the result of amoebiasis, which is caused by the protozoan Entamoeba histolytica. This type of liver abscess is most common extraintestinal manifestation of amoebiasis. Clinical features usually appear within 8 to 20 weeks from primary infection. Most patients present with right upper quadrant abdominal pain and fever. Other symptoms that may be encountered are weight loss, anorexia, and hepatomegaly. We suspect the diagnosis of amoebic liver abscess when there is a history of travel to endemic areas such as India or Africa. Imaging, serologic, and antigenic tests help confirm the diagnosis. Ultrasound usually shows a solitary cystic hypoechoic cavity, most commonly in the posterior part of the right lobe. Drainage is not always required, but it can be diagnostic and therapeutic in some cases. It may be performed if the cyst is large or there is unresponsiveness to empiric therapy. The aspirate shows a brown fluid of necrotic hepatocytes, often referred to as anchovy paste. Treatment of amoebic liver abscess includes metronidazole or tinidazole. We then administer perimomycin to destroy the intraluminal cysts. Here is how the anchovy paste drainage of amoebic liver abscess looks like. Please notice this thick, dark, chocolate brown fluid. A 17-year-old boy presents to the clinic for a follow-up visit. He has a past medical history of beta thalassemia major treated with frequent blood transfusions. He has recently noticed diffuse joint pain and darker skin discoloration. He's also lost interest in having sex with his girlfriend. His vital signs include a temperature of 36 degrees Celsius, blood pressure of 110/70, heart rate of 87 beats per minute, respiratory rate of 16. Physical exam reveals right upper quadrant tenderness. ALT is 400 and AST is 350. Fasting blood glucose is 150 on 2 separate occasions. Which of the following is the best treatment option for this patient's recent complaints? A. Penicillamine, B. Zinc, C. Deferoxamine, or D. Phlebotomy. Pause the video and take a moment to consider this question. This boy has a past medical history of beta thalassemia major, treated with frequent blood transfusions. He recently noticed diffuse joint pain and darker skin discoloration. He also lost interest in having sex with his girlfriend. This is known as decreased libido and may be caused by hypogonadism. Physical exam reveals right upper quadrant tenderness. ALT is high with the level of 400 and AST is high with the level of 350. These values are consistent with hepatitis. Fasting blood glucose is high with a level of 150 on 2 separate occasions. This indicates new onset diabetes. Arthalgia, bronze skin discoloration, and decreased libido, hepatitis, and diabetes are all signs of hemochromatosis. This patient likely has secondary hemochromatosis due to frequent blood transfusions. Therefore, he needs iron chelation therapy with drugs like deferoxamine, deferocerox, and deferriprone. So the correct answer is option C. Again, here's a slide reminding us of the management of hemochromatosis. Pause the video and take a moment to consider the slide once more. Let's discuss why other options are incorrect. Options A and B are incorrect because penicillamine and zinc are used to treat Wilson's disease, not hemochromatosis. Finally, option D is incorrect because although phlebotomy can be used to treat hereditary hemochromatosis, it is typically avoided in secondary hemochromatosis. This is because the patient has an underlying severe anemia. Phlebotomy, in turn, would likely worsen his anemia. And that concludes the section.